Today, I'm going to talk about the transforaminal endoscopic spine surgery in thoracic disc herniation. Yeah, recently, we have been surprised figure out the dramatic adoption, more and more uses of the spinal endoscope has been taking place a lot, right? And also tons of the evidence paper and presentation are coming out every day. I don't know. I'm not sure you have the same page with me about the transfer endoscope discectomy for the treatment of thoracic disc herniation. Just bring you guys up to speed up today's lessons. Let's move on to the topic today. It's about the transfer endoscope in thoracic disc herniation. This is my disclosure, and I have before going further, I'd like to share the three cases briefly for asking your opinion for the treatment option. The first poll is about this patient, 49 male patient having a progressive leg weakness, gait impossible, actually paraplegic status with voiding difficulty and sexual dysfunction. So you are seeing the MRI thoracic spine T7, 8, 9. There is a huge disc herniation, right? Compressing this spinal cord, highly canal compromised at the 2 level. It is very sad situation for the patient, right? So among we have the various kind of option for the treatment from the posterior approach, instrumentation without instrumentation, and the rattle transthoracic approach, other kind of the MIS solution for that. So what is your option, right? You can you probably need to take time because the patient had a very serious neurological deficit and the challenging cases. There are two options of the endoscope, transforaminal endoscope, interlaminar, right? Other the popular option of the MED, tubular surgery, or the BDO thoracotomy and discectomy, right? Are you ready? Okay, let's see the results. 3, 2, 1. Okay. It's a very unusual situation. I have actually expected nobody gonna put transfer endoscope surgery in this huge discarnation. Yeah, it's great because today is the time for learning the endoscope, and the topic is the transfer endoscope surgery. And let's move on the next case. Male, 56 years old. Patient have both leg weakness, dysphagia, gait swaying. It's not the pelagic status, but paresis. Also, he had been suffers from the impotence. The level is T12 iron. There's a huge central disc herniation. There's no calcification on CT scan. Yeah, this is giant thoracic disc herniation at low thoracic level. Right, we have the same question and list of the answers. Right, are you ready? We're gonna see the result. 3, 2, 1. So a little bit more bunch of persons have voted the transfer endoscopic spine surgery. is about the half. There's no participants who have the opinion of MI's retroperitoneal approach and innovative fusion. 0%. That's quite interesting. Okay, let's move on to the next case. Now, this patient has both leg weakness as well, grade 4, dysager. Female patient, the level is low thoracic as well. Right? There's a little bit the spinal stenosis, recurrent flavum buckling as well, and also has a little bit kyphotic angle, right? So I'm gonna ask you your opinion. Broad base stenosis and the bulging disc. Okay, are you also ready to vote? Okay, let's see the result. 3, 2, 1. 41 persons, they have the favorable opinion for transforaminal spine surgery. Discectomy is quite interesting. I think that you, among the participants, you guys already have been many experienced guys in the case in the transforaminal endoscopic surgery. Anyway, let's move on to the topic. So I have published this kind of brief review article. It's not the systematic review. It looks like the narrative review because the evidence of the thoracic spine surgery still lacks of the evidence. Just a little bit. There's not the many publication about the MIS for the treatment of thoracic disc herniation. So based on the evidence I have, that draw this kind of the strategy for treatment of disc herniation. Disc herniation, I classify the disc herniation and giant disc herniation. Most of the disc herniation are located in central or paracentral. So paracentral disc herniation is quite a good indication of the transforaminal endoscopy spine surgery, discectomy, right? Because of location favors transforaminal access. So other cases of the large central and the giant disc herniation is very, sometimes it's gonna be risky to adopt the endoscopic spine surgery right there. So I have bunch of experience of the MIS, including the endoscope and thoracoscope and other kind of MIS fusion in the thoracic spinal disease. So today I'm gonna focus on the transforaminal endoscopic thoracic discectomy, right? There's also other kind of the endoscope assist discectomy. We have used called the BAS, right? This kind of the thoracoscope also has the long history of the evidence for that. These are the bunch of papers related to the thoracic spine I have published. And let's see this classification system endoscopic spine surgery. We have in the left side, left column, there's a full endoscopic decompression. We also put some technique of the thoracic spine. There is a thoracic endoscopic ULBD procedures, also the transforaminal endoscopic and discectomy procedures. So because the interlaminar discectomy in the thoracic spine, it is not accepted well. No paper yet, because except only one paper by me. So we cannot put the interlaminar endoscopic thoracic discectomy right there. So this is the very unusual case, 66 male having the progressive paraparesis and the non-dermatomal dysphagia and the severe uh, burning, etc. Also, patient had the impending caudate keener. So just look at the MRI there. There's a large disc herniation, but it's not easy to identify the margin of the disc and normal margin of the thoracic cord. If you see the MRI axial in detail, there's a 3 component there. Yeah, that is the migrated dorsal side spinal cord from the disc level. It's very unusual. So in this exceptional situation, we can use the translaminar, interlaminar thoracic discectomy procedures. The yellow one is a severely compressed thoracic cord. So we have the many options for that as well. So let's ask you guys what's your option you have preferred in this exceptional, unusual cases. We have the same list for that. Are you ready to vote? Let's see. 3, 2, 1. Yeah. So most of you guys love to do the interlaminar endoscopic discectomy. So transforaminal endoscope, yeah, it's technically location, considering location of the disc hernia, transforaminal endoscope, it cannot be used in the special cases, right? Okay, let's see the other page. This is I have done the, actually it's not interlaminar, it's involving interlaminar and the translaminar. I need to resect all the way of the facet, like the hemilaminectomy done by endoscope, because of the bunch of the rupture disc herniation located in the dorsal side. So you can see the rupture. I am grasping the rupture disc and the contralateral dorsal side. It has been migrated from the disc level to the spinal canal, right? Very unusual cases. After that, it's a traditional discectomy procedures. So the, you might be, hopefully you understand why the transforaminal endoscopic discectomy cannot be used in these special cases. So this is the pre and post-op MRI and follow-up MRI. You are seeing the gait improvement. Before the operation, he couldn't walk at all, right? Still gait swaying there, but patient pain and dysphagia, walking ability have been improved after this discectomy by transforaminal endoscope. So let's move on. The main topic today is about the endoscopic, transforaminal endoscopic thoracic discectomy procedures. So I'm gonna review the some literature. This just a few paper have been published right now. The first paper published is this paper, percutaneous endothoracic discectomy, Journal Minimal Invasive Neurosurgery in 2010, just the 10 years back exactly. You can see the figures, but I'd like to share my opinion, the limitation of the transforaminal, why the transforaminal endoscopic discectomy and the thoracic disconation has just a couple of the papers yet. That is due to, firstly, incidence of the thoracic disconation quite lower than the lumbar and cervical. Yeah, the second one, the other reason is that the techniques is very challenging and it demands a high level of the experiences about the transfer endoscope discectomy. That's why the today's topic uh, so it is tier 4 for experienced endoscopic spine surgeon. So anatomical consideration for treatment of thoracic disc herniation, you can see the MRI right corner right there. There's a huge disc herniation, a large disc herniation, and it's centrally located. You you probably know the basic knowledge, the pattern of the disc herniation, the thoracic spine. It's a most common type is a central disc herniation. Foraminal or paracentral is a little bit uh, not common compared to central disc herniation. In this kind of central disc herniation right there, so once you approach your endoscope, so you can go through this way, but by this trajectory, you cannot reach out to the main part of the thoracic disc herniation right there. So by in the lumbar spine, it is possible to make the rubber, right? Rubering technique is possible in the lumbar spine, but because of a rib cage and shape and angle of a rib, it cannot it cannot be done properly, right? That is why in this case, there's a large disconnection, centrally large disconnection spiking, so spinal cord directly the middle portion of the ventral spinal cord. So I have approached the endoscope right here, and you can see the post of MRI. There's a little bit remaining annulus there. It looks like compressing the spinal cord a little bit. Of course, the patient's symptom had been improved because the main part of the disconnection already extruded, right? But the post MRI, it didn't make the beautiful post MRI like in lumbar spine or cervical spine. Of course, this patient have the remodeling of annulus uh, after 38 months follow-up MRI done, right? So to overcome this kind of limitation of transforaminal approach, I have combined of microendoscopic technique and the full endoscopic techniques. I already published the microscopic technique about oblique paraspinal approach in the thoracolumbar and the thoracic spine, disc herniation, and the neurosurgery. Also, I'd like to combine this technique, my colleague's paper here. So just see this case. Patient was the 41, bilateral leg pain, numbness, and dysphagia below the periumbilical level. There is a little bit the muscle tightness and the hypertrophic change. You can also see this MRI, all right? So there's the large disconnection compressing the spinal cord. It's making hard, right? So that's why this is one of the most common type of thoracic disconnection, right? So because lip cage may hinder your anatomical approach trajectory of the thoracic endoscope. So roughly I'm gonna make the open up the foramen first, and then approach the guy, introduce the thoracic endoscope like there, and take it out. This is 3D CT scan. First job should be done by oblique parasmal approach. This paper, all the cases had been done 2014 and 2015. So it is before roughly the introduction by the big endoscope of the spinal stenosis. That's why I have used this kind of the technique before. After the compression open up the foramen enoughly by the microscope, I approach the endoscope like there. And you can compare the pre and post op MRI done. This is the MED approach firstly, and this is second approach of endoscope. This may enhance your safety because of thoracic spine. Most important issue of the surgery is the safety issue, right? Of course, the thoracic cord, the central nervous system, is very vulnerable any kind of the additional injury of the any kind of the surgical instrument surgical procedure itself. So when you follow MRI, we can see the perfect remodeling of the posterior annulus. Right, this is also embedded, and 1 year follow-up MRI. You can see the nicely done remodeling of annulus right there. Yeah, this is the first cases I'd like to ask your opinion of the surgical approach. Two-level giant disc herniation. Patient has the progressive leg weakness and gait impossible and sexual dysfunction as well. So on myelogram, I love to use the myelogram, myelocity myelogram in the case of thoracic disease like that. You can see the completely blocked the spinal cord by the huge disc herniation, right, to level. So if you search the article, the treatment option of giant thoracic disc herniation, these 6 papers are all before. Almost all cases are thoracotomy, bilateral fastectomy, mini thoracotomy, open thoracotomy, like that. No cases, no surgical experience report about endoscope spine surgery right there. So I remember most you guys love to do this transfer endoscopy. It's very incredible choices from the participants, right? So first step I have done is opening the foramen using the tubular surgery. All right. This surgery was done 2000, maybe 15, 14. Anyway, if this kind of patient visit me again, now I'd like to use the large scope instead of the tubular surgery. Anyway, unfortunately at the time, the video recording system was out of order. These figures was taken by international fellow by his cell phone. It's very lucky for me. And you can see the thoracic cord, some slightly see the epidural fat there, and large and huge rupture fragment. And once I remove the thoracic giant disc herniation, this is the initial discectomy here. This is the remnant disc here. You can see this slowly going down the thoracic spinal cord into your center of the endoscopic view, and dissection of the disc from the thoracic cord should be done meticulously and gently right there. Of course, I have used the neural monitoring system because this kind of surgery has should be taken, uh, attention should be, yeah, taken, right? This is step by step. Finally, once I remove the main part of the thoracic disc herniation, you can see the PLL intervertebral nucleus and the spinal cord and the dorsal side. 11 o'clock, there's a lateral edge of ligamentum flavum there. This is post-op MRI immediately. There's a looks like a little bit swollen spinal cord. Most of the disc herniation were taken out nicely. 6 months later, I have followed the MRI. Now you can see the very nicely remodeled annulus and the calm down thoracic cord right there. And axial image also have shown the remodeling of annulus, right? So actually, this bunch of cases has been published last year under the title of the minimal invasive hybrid technique to approach intracranial herniated thoracic disc herniation like this. So this is the third case I have circulated you guys. This patient had the broad-based disc protrusion with stenosis at the thoracolumbar junction level, right? Personally, I have, this is not the indication of the just decompression because the compression side is a circumferential. Ventrally, there is a broad-based disconnection. There's also dorsal stenotic component. There's a little bit the sort of the OLF in the left side, calcified, then the flavum thickening and calcified, the compressing the central ventral side and the dorsal side. Also, patient have the compressed kyphotic posture there. So in this situation, MI's fusion is preferred than the decompression alone. So I have used the endoscope assist thoracic interbody fusion, and they put the cage like there. Initially, this is a hybrid cases. Just I presented you guys right there, and after discectomy done, this kind of the system, I put the cage and I put the percutaneous pedicle screw. This is endoscopic view. After initial deburking of the nucleus by the Inspire and the special tool of the discectomy, I can reach out the compression part, main part of the thoracic disc herniation. After done the central discectomy and removal of the hernia, I can see the ventral endoplate preparation well and put the pedicle screw. This patient was followed more than 3 years. Symptoms free status going well since the surgery. So I'm gonna move on the another giant thoracic disc herniation. So I have treated this kind of the giant large disc herniation, especially in most cases small disc herniation paracentral, making the truncal pain. I have not operated in most patients. So that's why you guys have seen the very serious and challenging cases from my presentation. Anyway, this is most recent patient, 56 years, male. Also, he have suffered from the both leg weakness, gait problem, impotence, right? There's a large disconnection, little bit they migrate cranially and the caudally, right? So what gonna be the ideal solution for the treatment? I also have the bunch of experience of thoracoscopic discectomy. So personally, I think the for reach out the corner and corner of the disc herniation, this kind of yellow, you can see the yellow line resecting the corner of the vertebral body. That's procedures. That's gonna be resection of the additional bone margin should be conducted together, right? So for that, I think the lateral approach, thoracoscopic and resected the posterior corner of vertebral body involving the index disc level is the basically ideal. Theologically, is gonna be best solution for this kind of the large disc condition, because we don't have to manipulate the spinal cord. So it's ideally we can make the best solution for safety issues for that. But the level is lower, so I'd like to adopt the endoscopic procedures for this kind of for this patient, because thoracoscope, thoracotomy, and the thoracoscope surgery eventually, in most cases, we cannot exclude the kind of the morbidity and complication related to surgical approach. That so that's why I'd like to full endoscopic transforaminal discectomy at this thoracolumbar junction, right? You can see the pre-and post-op MRI, the yellow is spinal cord, the nearly full expansion of the spinal cord after surgery. This is the follow MRI there. The reason I followed this MRI, the patient, is not any neurological patient. I'd like to confirm the improvement to this of the spinal canal. I'd like to circulate this kind of the improvement image with the patient. And you can also see the resected margin of the endoscope. Nowadays, we have the very nicely tool of the drilling system, and this kind of cutting the corner of the vertebral body should be done, could be done with the walking cannula as well. That's why you can see this kind of image, right? But I'd like to share very interesting, very positive finding, the transforaminal endoscopic discectomy. This patient is 56-year-old male. Pre-op CT scan, there's the no obvious central dislocation, DDD vacuum disc on the lower lumbar. But the 1-year follow-up CT, there's a new developed gas cascaded of the disc situation right there. There is a usual progression of the degeneration in most patients. But you can also see the upper level, index level, preoperatively. You can see the disc degeneration pre-operative CT scan. But what happened in post-op CT scan 1-year follow-up is a very unusual improvement of the disc status, right? So I have thought why this happened. Why this happened, you think? So by this presentation, so you guys participants may suggest your opinions why this kind of disc degeneration can be occurred in following the thoracic discectomy, right? I think the my personal nuance is exposing of the cancerous bone may enhance the release of stem cells which help the healing the annulus and nucleus. I'm not sure what's going to be the real causes. Okay, this is my personal experience for the transforaminal endoscopic discectomy. This is take-home message. So we have, contrary to the lumbar and the cervical spine, we have more options for treatment of thoracic disc herniation, traditional the thoracotomy, thoracoscopic approach, endoscope, tubular surgery. But important thing is the MI surgeons like you. I hope you guys gonna be learning the old kind of the MI solution for the treatment of the thoracic disc herniation. Thank you for your attention. So Stefan Hellinger will take over the second presentation, and then we're gonna have the discussion with together.
Well, Dr. Kim, thank you very much for a wonderful presentation. I do want to speak to the audience quickly. I do see some questions coming into the Q&A, and they may be reflected on your presentation, Dr. Kim. So I want to take a minute or two to answer these two questions that did come in.
Okay.
Adriana, if you don't mind, can you please translate those two questions from Dr. Alaba?
When you go into the disc, do you use the oblique incidence angle more? And is radiofrequency dangerous? What is the range of radiofrequency that you use in the thoracic spine?
Basically, I have used the same frequency of the radio frequency in the lumbar spine, but important issue for more importantly, so we're gonna make it short exposure of radio frequency, because once you expose the very close disc structures close to the spinal cord, you have to keep attention not to damage and any kind of thermal damage of the spinal cord and other neural structures. So basically, I have used the same frequency and lumbar spine, but more important issue is the make it short. Action time should be shorter than the lumbar spine usually. Yeah, angle regarding the angle, it depends on the location, level of the thoracic spine. In the case of thoracic spine, there's the reserve angle make the levering. So before coming in the target, we need to open up the foramen, right? Resection of facet, and they make the more room involving the pedicle. That's why we not to catch up with the rupture disc herniation at the mid thoracic level, but the low thoracic level is quite similar with the lumbar spine. So in that situation, we can make the adjust the angle accordingly, location of the nucleus rupture disc.
Thank you very much, Dr. Kim. All right, now that's the only questions that I wanted to present for now. Dr. Hellinger, the stage is yours to present.
Okay, let's go into screen. Oh, we got it. Oh, yeah. First, good morning, good afternoon, good evening, where you're coming from, to everybody. I've seen we have a widespread participants from all over the world, from east to west. So today we chose a very special topic with the thoracic spine. In my personal experience, for the long-lasting time I'm doing endoscopic surgery, especially the thoracic spine gave a big advantage compared to other techniques. If you have the skill set to work with an endoscope thoracically, you can really help your patients. You can diminish any collateral damages due to the surgical approach, and you even can diminish the risk of any complications. Meanwhile, Luke showed you really interesting cases, interesting techniques, especially his hybrid. I want to go a little bit more on the technical aspects, how to do a proper transforaminal endoscopic approach, how to do a proper transforaminal decompression, and to work on the safe side. So when we look in the history, thoracic disc herniations are an old issue. Even in 1838, we got the first description of it. The first surgical treatment was at the beginning of the disc surgery in the beginning of the 20th century in 1931. At this time, they even didn't know whether it's a disc or it's chondroma. But, and our pioneers of discectomy, Mixter and Barr, reported 2 cases of thoracic discectomy, but altogether got a big problem. She got complications up to 66%, especially when you do dorsal laminectomy. And when I remember to my neurosurgical training, I did it in Zurich with Professor Benini, he told me, don't even watch at the spinal cord in the thoracic spine. It can be dangerous. So this is an area compared, for example, to the lumbar spine, you should be very careful. So when we approach these thoracic problems, the first question is it really the spine? The first thing you have to exclude is always a cardiovascular origin. We have a nice story here in Germany, 2 orthopedic colleagues. One colleague came to the other, said, oh yeah, I have thoracic pain. I know it's my thoracic disc. I know it very exactly. And the other colleague said, okay, I start to treat your spine on the thoracic spine when you tell me this. And 2 days later, this colleague was dead by a heart attack. It was a big malpractice issue, but I learned out of this, always exclude cardiovascular origin. Then you know there are a lot of other things that can lead to any thoracic pain. It can be tumors, metastasis, fractures, infection, even from the mediastinal structures, pulmonary complications. You know, we are living in a world of corona, though everything seems to be corona influenced. Everything is possible, but before you focus, even when you see disc pathology, please close this out. What are the common signs? You know, first is pain. That's the reason patients will come to you. It can be a local dorsal pain. It can be in the midline. It can be paramedian. You see even pararadicular pain with a belt-like ventral radiation on the left or right side. You can be confronted with mixed pain with radiation and focal points. And on the other hand, if you have these huge cases, as we have seen before by Luke, neurological signs, you can have segmental hype or dysesthesia. This is what you see very often. You can find a focal intercostal muscle weakness. It's difficult to figure out. Protrusion of the abdomen, sometimes you see it. And in worst cases, myelopathy, what means weakness of legs, problems with walking, balance, bowel function, bladder function, or sexual function disturbed. And then the big question, the indications for these surgeries. At the end, it's always a clinical sign and how much is it the patient bothering. Important is if you consider the decision for any surgical approach on the thoracic spine, you have to figure out the compromise between risks and benefit. And one of the big benefits on the thoracic spine is even when you remove a little bit more than only sequestrated disc, there's no high risk of instability. So for me, indications are axial or local pain, acute myelopathic symptoms, radicular pain symptoms with unsuccessful conservative treatment, mixed syndromes, and very important always, all these symptoms or syndromes must be correlated to the diagnostic pictures like MRI or CT scan. So when we go over to a surgical technique, we have to figure out what should be the best. We have different surgical techniques as we've seen before. We have the dorsal laminectomy, we have the costotransversectomy as an approach. We have ventral transthoracal approaches, transpedicular approaches, or even the fusion technique. Then This was the first endoscopic technique on the thoracic spine, the thoracoscopic discectomy. Meanwhile, most of the cases we do with an endoscopic posterolateral discectomy. And even here we have different techniques, transfacet, pedicular or transvertebral. And we have the endoscopic in the laminar techniques. Back to the common things, when we speak about minimal invasive spine surgery, especially in the thoracic spine, it's important. In general, we have to consider that surgery is trending toward minimalizing surgical procedures, including spine surgery. And the advancement in the instrumentation, fluoroscopic imaging, and high-resolution endoscopic video imaging systems, along with the accumulated experience in endoscopic spine surgery, nowadays make all these minimal invasive or endoscopic surgeries possible. But these techniques requires more precise, delicate, and effective methods for spinal decompression. One of the benefits is we don't destabilize the vertebral segments, and we can safely treat multiple level symptomatic spinal disc, spinal stenosis, or high-risk persons. So I compare the work in minimal invasive spine surgery or in endoscopic surgery like a sniper. You have to fix really well your target, and then you have a really diminished collateral damage. On the other hand, always we have to look, is endoscopic spine surgery a real minimal invasive technique? I would say yes, because it reduces the physical trauma to a minimum while achieving maximum results. You have a balancing of the healing and harming potential of a given treatment. It is less invasive, less aggressive, or even only a minimal incisional surgery. Everybody knows these old advertisements from the Laser Spine Institute with a small band-aid on the back, but this is not everything, because most of the surgery happens on the spine, not on the skin. So the goal is always to reduce blood loss, postoperative pain, metabolic response, and even you need an acceleration of the recovery period and an improved clinical outcome. So as I told you, the first endoscopic technique had been the video-assisted thoracoscopic surgery. It was introduced by Rosenthal in 1994. It was a smart technique, but nevertheless, you need very special anesthesiologic considerations. You do it in side positioning, you do the approach from the side of the herniation, and you have to collapse the ipsilateral lung, and besides this, you need fluoroscopic assistance. So the endoscope is normally placed in the posterior axillary line, and the instruments are placed via 2 ports in the anterior axillary line. So you have different approaches for your instruments and for your scope. And you have always to be careful not to run in complications, for example, by adhesions of the pleura. Then the first step was always an extensive resection of bone. You see here how you would take away a part of the vertebra. Then you can even remove huge or even calcified hernias. So for these special cases, it's a smart approach, but it's not really less invasive. Here you see the endoscopic visualization. When you do these surgeries, you see the disc, you see the bone, and how you release this. But never forget, there was a huge study for doctoral degree in Germany, and there is at all a rate, I don't want to say always complications, in unexpected events up to 23%. And so the decision for the transthoracic approach should be done very careful. The other option came with the introduction of the working channel scopes, and we call it full endoscopic posterolateral decompression. Here you have a placement of a working channel scope via a foraminal way. We have now very special instruments for decompression and discectomy through the scope. It is important that the working cannula passes rib or with a partial bony resection of the rib. And to reach the disc hernia, a bone removal is necessary. So I want to show this old discussion about the different techniques. We have, to my opinion, now 3 different techniques in posterolateral approaches. One is the inside-out approach. It's going back to Tony Young, started with the YES system. We are using it even still with the disc FX system by Eloquence. I didn't include it in this lecture, but especially disc FX in selected cases of contained hernias in thoracic spine can be really a smart technique to solve problems. Going back to the questions of the energy, as long as you applicate this radiofrequency intradiscally, it's very safe. Everybody knows, or I hope everybody knows, these researches we did supported by Eloquence to the safety of the radiofrequency intradiscally. And it can be helpful because of the small cannula by disc FX. It's very easy to bypass any ribs and go in the discal space. But then we got in the evolution of the approaches, the outside in technique. It was Tom Hoagland mainly who promoted it. Here he developed techniques to remove partially by reamers or later by burrs facet joint and go from outside to the disc hernia. I personally, meanwhile, prefer the outside approach. That means we create an access to the spinal channel by controlled extensive bony decompression. And the working cannula keeps totally outside of the annulus. And we don't try to enlarge the defect in the disc with our instruments. So even for the thoracic spine, I prefer this technique. Then what is appropriate endoscopic technique? Why outside? We keep a structural preservation of the disc by decreased discal injury. We want to preserve as much as possible anatomical structures. On the other hand, you need an adequate decompression, and all types of herniations, high migrated, non-migrated, can be targeted. And very important, it's not many people know about, it's called, we have no wedge effect. Because one of the problems, I found it was in a paper of 1993, the so-called wedge effect, when you push a cannula from an endoscope in a disc, you press all the disc material in. And when the patient is after surgery going back to an axial load, it can come back, and this is called wedge effect. And this is sometimes the reason that after 1 or 2 days, the patient is running back to the old symptoms. And if you keep outside, you reduce the risk of any reherniation. But back to thoracic posterolateral endoscopy, the posterolateral transforaminal approach allows the less aggressive surgery for the thoracic spine. And by consideration of the anatomic special features, a proper discectomy decompression can realize. And here you see the difference to the lumbar spine. You have to consider the lung. You have to consider not to come too close to the spinal cord. And on the other hand, you have limitations by facet joints and ribs. Here is a nice paper by the Cleveland Hospital about the different levels in approaches. It's very important to look at which level you work. Yeah? And this reflects what I always say for the transforaminal approach, that the transforaminal discectomy from T6-7 to T12-L1 is very easy. Above T6, T5, it's really difficult to make a proper transforaminal approach. When you do this approach, there's one anatomical structure you have to be very, very careful about, and this is called artery Adamkiewicz. For example, I got one case. We did endoscopic decompression with an endoscopic fusion thoracically, and the patient developed after this surgery temporarily hemiplegia. And we did everything to figure out why this was a hemiplegia, and at the end we learned that we affected during the surgery the Adamkiewicz artery, and this reduced blood supply led to some neurological symptoms, as you can see here. So always be careful when you do this. There's a high variety of this artery, but when you see it, keep away. Then technically, it's important when you do this approach, you have to do at one side sometimes a partial resection of the pedicle and the rib joint to get an approach. Then, as we saw, a partial resection of the facet joint for decompression. For decompression, we saw the hybrid technique of Luke. I do it with the working channel scope 2. And one of the important tricks is a little bit similar, but not so expressive as we have seen it in thoracoscopic approaches. You can remove partially bone of the vertebra, especially of the corner here, and go under the ligament without coming too close to the thoracic, do your medial herniation. And this is the main trick that limits this work, and you can go in. So when you look here and you see at this picture how different the rib angle is according to the level. And this gives you different options for the approach. And this is the area at the end you have to remove to come in a proper foramen. And this you have to do when you placed your cannula with the kerosene and the high sweeper to make a proper approach. Here you see again how these anatomical structures are the capsula and the rib joint, and you see how we have to free and how to remove even the soft tissue of the rib capsula. Here's the rib joint to come into the foraminal area, and then you can go to the herniated disc. It's tricky, but when you have a proper planning in front, you can do it. Here you see furthermore how we remove the bone of the vertebra. I use mostly the high-speed burr to go under the posterior ligament, to go in, and then when we released enough, you can easily remove these, for example, this sequester in the thoracic spine to get a proper decompression in the spinal channel with a reduced damage of the disc and of the neural structures or even of the facet joint. In my cases, we did a retrospective cohort study with the inclusion criteria that all patients with DDH treated with working channel transforaminal endoscopy between 2015 and 18. 14 patients we collected with these criteria, and we demanded, like always, 6 weeks of conservative therapy. And we used this special technique, what I showed you. When you look here, we have all these patients. Okay, these are similar data, but according to the pain McNabb score, we got more than 75% good results, and the acceptance was very well. So the pain improved from VAS 8.9 to 2.8. In McNabb, we got 71% of good or excellent outcome. 93% of the patient reported a good or excellent acceptance of the procedures, and all neurological disorders, mostly belt-like dysesthesia, improved, and we got no complications in this surgeries, but 2 patients, poor, had to undergo a resurgery with fusions. So then we got the question, can you even work on calcified hernias? You see here the situation, you see spinal cord, you see here the calcified hernia, and you see how you can approach it. Again, the trick is to remove enough bone from the vertebra, then you can go under the hernia, and when you have done this, you can mobilize and remove this calcified hernia. You see it here without touching too much the spinal cord. You see, especially in this case, how safe eloquence radiant frequency is. We work very close to the spinal cord thoracically, and we use the hemo mode and in short bursts, so we can really stop any bleeding in the spinal channel without affecting the spinal cord. Here's a very special case. Fortunately, I don't have the video to this case. These are very special situations on the thoracic spine, what can be treated even with an endoscope. Here you have to remove a lot of the lamina. The other consideration here would be an interlaminar endoscopic approach for this very, very special situation. At the end, I want to show sometimes there are real limits. You see this huge calcified hernia outside of the disc space. This is a situation. Here is the limit of the endoscopic transforaminal technique. This keeps still for an MED or an open technique, or for a thoracoscopic approach with a huge resection of the vertebra. So we can conclude that the surgery for thoracic disc herniations has undergone a fast evolution during the last 40 years. The traditional dorsal laminectomy approach to the thoracic spine is now considered as obsolete. Transthoracic or torsolateral approaches are used by most surgeons to remove disc herniations. The development of minimal invasive endoscopic approaches for disc removal might be a further step towards the reduction of surgery-related complications and to improve the results. And the endoscopic thoracic discectomy proves to be a highly efficient surgical procedure for thoracic decompression with a lower complication rate in comparison to open procedures. So endoscopic thoracic discectomy is an effective procedure with 98% of morphological reduction of the extrusions. You see always these nice pictures, but at the end, the thoracic spine is very complicated. The reduction of pain is only mostly up to 70%, and the motoric and sensoric disorders up to 80%. But the complication rate of a thoracoscopic procedures ranges around 6%. Meanwhile, we have only less than 1% for posterolateral endoscopic procedures, and this is acceptable compared to other techniques in thoracic spine. So I thank you for your interest. I hope we will run in a good discussion. You know, it's a very special topic. Thank you.
Thank you very much, Dr. Hellinger. Excellent presentation, as always. I do see some questions that have come in from Dr. Sohail, and I do want to speak to the audience. If anybody does have any questions they'd like to ask to either Dr. Kim or Dr. Hellinger, you're invited to send in your questions into the Q&A or the chat, or raise your hand to speak to them directly. So Dr. Hellinger, this one comes from Dr. Sohail. What are limitations of endoscopic technique in thoracic spine?
Oh, I showed one limitation. This was this huge calcified hernia. This is a situation where endoscopic approach really becomes experimental. You can try it, but I would say in this case, I would prefer to go over to an open surgery. Then one of the limitations I really see is the level. As I told you, above TH5, depending on the rib angle and the anatomy, I don't recommend to try an endoscopic posterolateral approach because it's very difficult, very limited, and it can bring you in some complications. The other limited situation are really huge hernias with degeneration of the rib facet joints and hypertrophia. Here, I would really prefer the technique by Lou with a hybrid technique to make a proper bony decompression via an MED system. And then you can place, when you shape the nice anatomical situation, the endoscope. These are my limitations for these approaches. On the other hand, I see a lot of advantages of the endoscopic procedure compared to all the other techniques because it's safer, it's easily and you can achieve a lot of good results.
Thank you. Dr. Kim, do you have any comments on the limitations?
Yep. Contrary to the lumbar disc herniation, most of the thoracic disc problem, they have a little bit long-lasting symptom duration preoperatively. It usually makes the adhesion more inflammation than the cervical and lumbar spine. So technically, even though the CT scan doesn't show up any calcification, most cases they have a little bit more sticky and inflammation around the disc herniation. So technically, it's not even though the simple looks like the paracentral disc herniation at the 10, 11 level, it looks like easy, but you have to keep attention when you try to retrieve the fragment, because a lot of inflammation and adhesions are there. So always keep in mind not to make any complication. Personally, I recommend the neuromonitoring if it is possible in your institute. Yeah, technically, so seeing is not all things. So we need to see the underlying problem around the disc hernia, right? So other issues already Stefan addressed, commented nicely.
Excellent. Thank you very much. Next question is there any preference for left or right side herniation, right side approach? Sorry about that. Dr. Kim, we'll start with you.
No, there is no preference right and left. Just we have decided based on the location and type or shape of the disc hernia and the actual image, or the symptoms. In the case of the left side, the axial pain, dominant truncal pain, unilateral side, we usually prefer that side.
All right, Dr. Hellinger?
It's the same. On the thoracic spine, the side of approach depends on the clinical sign, what is the most attached nerve or thing, and secondly, on the anatomical or pathological structure of the stenosis or disc hernia. There you have to base my surgery. There's no limitation whether I come from right or left. I told you, we spoke about Adamkiewicz. It can be a problem sometimes that we have a left or right-sided Adamkiewicz, but our goal is to give the patient a relief of his symptoms, so we have to choose our side according to his problems.
Thank you very much. I have one question directed to Dr. Kim. Dr. Kim, how far from midline the tubular approach before endoscopy entry?
So in AP, draw the line, the lateral pedicular, lateral pedicle on APC and fluoroscope, and it usually 3 to 4 centimeter from the midline in most patients. So we can say that 3, 4, sometimes 5 centimeter from midline, but it depends on the patient, the size, right? I personally recommend you should read my article published about that, oblique paraspinal approach, neurosurgery. And there are 3 papers about that kind of techniques. We describe the techniques in detail in the manuscript.
Dr. Hellinger, would you like to make any comments?
No, I haven't anything to add to this problem tubular approach is quite different as a transforaminal approach. So you make your radiographic or fluoroscopic control, and then you place it according to the facet joint and the lamina.
Excellent. All right, I do have a hand raised. Dr. Jabri, I'm going to allow your mic to be on, so I'm going to allow you to talk. If you can just unmute yourself on your end.
Hi, do you hear me?
It's a little choppy, but
Do you hear me now?
Dr. Kim and Dr. Hellinger, can you hear Dr. Jabri?
No.
I can hear him though.
Hello?
Dr. Jabri, you can talk. I can hear you and I can relay your question.
Hello? Hello?
Now it's a little bit better.
Hello?
We can hear you.
That's
Yes.
good.
Thanks, Eloquence, for organizing this, and thanks for our distinguished speakers for this extremely nice webinar. You really highlighted the most important things and to take home messages. Now dealing with the spine thoracic disease is much easier for me, at least in my strategic planning. I just want to ask both our speakers, is there any difference between approaching the disc between upper and lower thoracic spine, not thoracolumbar junction, I mean upper and lower? I understand that the rib cage is more receding in the curves of the ribs and the upper spine, but when you are planning, do you have any special attention to things like for us to take home message? And the second question is, you usually do the thoracic anteriorly, I mean laterally, or you still attempt to do it transforaminally in case of paracentral disc herniation, which is calcified?
I think I'm going to start. First, I do make all of my these programs via the transfer endoscopy device. Even central or paracentral, I told you that I use the section of the vertebra, what allows you to go very midline. Sometimes I remove all these. Then the levels. I showed this picture about the different relations of the ribs and the rib joints according to the foramen. If you start, I don't recommend you to start at 6-7 or 5-6. This will absolutely fail, because here you have to make a proper placement of your cannula. You have to start to remove partially the rib joint, and then you come close to the foramen before you don't see. One of the tricks I'm using is always I do this procedure in local anesthesia. This is not only for thoracic spine, even out on the lumbar spine. And when you do your local anesthesia, you have a tiny needle to make the injection of the anesthetic. And when you place that tiny needle under fluoroscopic control, you can really figure out whether first you approach, or I get always a question, distance to the midline is well. Secondly, you figure out whether it's even possible to come into the foramen. So these are small tweaks, but in the beginning, I recommend not to go higher than 8-9, because then it becomes really tricky and difficult. Look. Maybe Dr. Kim has any recommendations still?
Sorry, I couldn't hear the Jabri talking.
No, the question was what tips we are giving him for an approach depending on the level, because anatomically we have different sizes of foramen hip joints for the different levels, and which tips we recommend him to go in the different levels.
I think recently we have the nice endoscopic armamentarium. The size of foramen, it doesn't matter. It's not a big deal recently. So I think I have used the tube MED system prior to put the endoscope through the foramen, but I think we can replace the tube by the scope for spinal. So it's a bigger one. So it looks like the another next adoption of the hybrid techniques. Instead of tube, we can switch to the big scope outside the foramen, and then for removal of the intradiscal portion and rupture disconation, compressing the cord, we can also use the small scope, the discoscope, small one. So I think we used to have the limitation regarding the issue of the foramen size and the level as well. But I hope we might be able to solve this kind of the anatomical hurdle right there. So if the patient having the large disconation is a little bit the T5, 6 or 6, 7 level, I love to try this kind of the coupling of the big scope outside the canal and small scope inside the disc, like that.
Thank you both. And thank you very much, Dr. Jabri.
Thank you. Very clear. Thank you.
I have a question from Dr. Sohail again. What's the uppermost level that one can operate in the thoracic spine? Dr. Hellinger, we'll start with you.
Okay, we told it before, for the postural approach, for me, the highest level is 5-6. Every case above, I don't consider really the technique as I presented here for the postural approach. There are some other techniques, tricks you can even consider in the higher levels, translaminar. It's depending on the situation. It's really even rare if you see in the higher levels any disc herniations. So it's a very seldom situation, but I would say, especially when you don't have the big skill set, limit is 5-6. Above, it's risky and difficult.
I actually have the same page with Stefan about the uppermost level limitation, because yeah, it's truly I have no I have no cases of the transfer endoscope. Example, the T45 or 56. All the cases I have experienced are the 7, 8 at 8, 9, 9, 10, 10, 11, etc. Yeah. But so if you see the recently published the paper by the Dr. Pe and Oriental Spine Hospital, he had the cases of the little bit upper level of thoracic disconation. But when I see the image of that patient, it is a special case. The problem is truly located inside the foramen, not the spinal canal. So in that exceptional case, we can try to use the transforaminal approach for retrieve the foraminal disconnection. But usually, if we can say that the uppermost level is about 5, 6, the same page with Stefan.